In the 1930s, uh, highly trained, well-meaning doctors actually believed the absolute best way to treat a psychotic patient was to deliberately overdose them with insulin.
Yeah, massive amounts of it.
Right. They would inject these massive doses to intentionally crash the patient's blood sugar until they literally lost consciousness.
They slipped into a coma.
Exactly. They slipped into a coma, hovering on the very edge of death, and they would leave the patient in this state for an hour, watching them sweat and convulse before frantically administering glucose to wake them up just before the brain damage became irreversible.
It's terrifying.
And the wildest part is they wouldn't do this just once. They would do this up to 20 times to a single human being.
It is a staggering piece of medical history. And, from our modern vantage point, it sounds like absolute barbarism.
I mean, it is barbarism, right?
Well, yes, but you have to understand the sheer desperation of that era. Clinicians were standing at the edge of an abyss. Schizophrenia was viewed as this relentless, progressive deterioration of the mind, a one-way ticket to a locked asylum.
Yeah.
They had absolutely no pharmacological tools to intervene, so they resorted to inducing massive systemic shocks, hoping against hope that they could somehow reset the brain.
Today, obviously, we look back at those insulin comas in horror. But the terrifying truth is, even today, our methods of treating psychosis are, well, they're far more blunt than we like to admit.
Oh, absolutely.
If you think about the healthy human brain as a vast, incredibly intricate symphony orchestra, you have billions of neurons acting as individual musicians and dozens of neurotransmitter pathways serving as the different sections, the strings, the woodwinds, the brass.
Right.
When you are healthy, there's a conductor ensuring that all of these sections play in perfect synchronized harmony.
And psychosis is what happens when entire sections of this orchestra suddenly ignore the conductor. The strings start playing a frenetic, terrifying waltz. The brass is blaring a chaotic march, and the resulting sound is just overwhelming. It's profoundly disorienting to the person experiencing it.
And for the first half of the 20th century, we essentially tried to fix this delicate symphony by throwing heavy furniture into the orchestra pit.
That is a very, very accurate way to describe it.
Which brings us to the mission of today's deep dive. We are going to trace the evolution of how we have tried to tune this orchestra, from the heavy furniture of the early 20th century to the molecular receptor-level pharmacotherapy we use today.
Exactly.
We are synthesizing this directly from Chapter 12.12 of Kaplan and Sadok's Comprehensive Textbook of Psychiatry, authored by John Kane and Christoph Carell.
It's an incredibly dense, vital chapter.
But for you listening, whether you are a psychiatry trainee, a clinician on the ward, or a medical student, our goal isn't just to read you a list of drug names and dosages.
Far from it. I mean, psychiatry at its core is the study of how the brain, the mind, and the human experience interact. And crucially, how that process can go wrong.
Right.
To understand psychopharmacology, you need to build robust mental models. We need to explore the specific mechanisms of these drugs, how those mechanisms manifest physically and psychologically in the patient, and what that ultimately means for your clinical reasoning on the ward.
You need to know not just what to prescribe, but exactly how to think about prescribing it.
Exactly.
Let's start by painting a picture of that abyss you mentioned earlier.
Yeah.
The dividing line in psychiatric history is roughly 1952. Before that, what was the actual day-to-day reality for someone diagnosed with schizophrenia?
Well, it was a life sentence. In the late 19th and early 20th centuries, Emil Kraepelin had conceptualized the illness as dementia precox premature dementia.
Right, meaning they thought it just inevitably got worse.
Exactly. The prevailing belief was that it was an inevitable decline. If you developed this illness, you were removed from society. Patients were housed in these massive, overcrowded asylums, often for decades, sometimes for the remainder of their natural lives. And because there were no antipsychotics, the treatments we now call somatic therapies were entirely focused on crowd control, just suppressing severe agitation.
I want to hear about the specifics, because suppressing agitation sounds like a bit of a euphemism. What were these early blunt instruments?
They were heavily reliant on profound physical sedation and restraint. Clinicians used chemical sedatives like bromides and barbiturates, but at doses that just rendered the patient unconscious or stuporous.
Just knocking them out.
Yeah. And they used hydrotherapy. Now, this wasn't a relaxing spa day. This often meant the wet sheet pack.
What's that?
An agitated, hallucinating patient would be wrapped tightly in ice-cold, wet canvas sheets, mummy style, and left for hours until they were physically exhausted and finally calmed down. Or they were placed in continuous flow baths for days on end.
Days. It sounds like sheer torture for someone who might already be experiencing paranoid delusions.
It was incredibly traumatic.
And the text mentions something called sleep treatments in the 1920s.
Yes, a Swiss psychiatrist named Jacob Clacy popularized this. He noticed that a patient seemed slightly less psychotic after surviving an accidental barbiturate overdose.
Okay.
So the sleep treatment involved keeping patients in a chemically induced, practically comatose state of continuous sleep for up to a week, sometimes longer, using potent barbiturates.
That sounds incredibly dangerous.
Oh, the physiological toll was massive. Patients regularly died of pneumonia or cardiovascular collapse.
And then the 1930s arrive, bringing the insulin comas we talked about at the start, but also psychosurgery, the prefrontal lobotomy. Igas Moniz actually won a Nobel Prize for this, which is, well, it's still a highly controversial fact today.
He proposed it in 1935, based on remarkably thin evidence. Researchers had presented data showing that if you surgically removed parts of the frontal lobe in chimpanzees, the animals exhibited less frustration and behavioral disturbance.
And he just leapt straight to humans.
Moniz decided to extrapolate this directly to humans suffering from serious mental illnesses, yes.
But did physically severing the frontal lobes actually stop the psychosis? Like if a patient was hearing voices, did the voices stop?
Well, the historical reports are a bit muddy, but the general consensus is that the lobotomy didn't necessarily eliminate the hallucinations or delusions.
Really?
Right. What it did was reduce the severe emotional anguish and the violent agitation associated with them. But the cost was catastrophic. By severing the connections to the prefrontal cortex, clinicians were destroying the very seat of human personality.
They changed who the person was.
Entirely. Patients suffered profound, irreversible deterioration. They developed impulsive psychopathic behaviors. They lost their executive function, their ability to plan, their ability to form complex concepts. They lost their essence. They became docile, but they were no longer themselves.
So we have wet sheets, weeks of sleep, insulin comas, and ice picks to the brain. And then a complete accident changes everything. It wasn't even a psychiatrist who found the first antipsychotic, was it?
No, it was a French Navy surgeon named Henri Laverie. In 1952, working in a hospital in Paris, he was looking for a way to prevent surgical shock.
No.
He was experimenting with a newly synthesized antihistamine called chlorpromazine. His theory was that by lowering the body temperature and inducing a state of artificial hibernation, patients would survive major surgeries better.
So he gives it to surgical patients.
Right. He administered chlorpromazine as a pre-medication before rolling them into the operating theater.
And what did he notice? Were they just really sleepy?
He noted something far more profound than just sedation. He described the patients as being in a state of euphoric quietude.
Euphoric quietude.
Yeah. They were awake, they could answer questions, but they were remarkably indifferent to the fact that they were about to be cut open. They had this profound emotional detachment from their surroundings.
Wow.
Labor was incredibly astute. He realized that a drug capable of inducing such profound, non-sedating emotional detachment could have massive implications for psychiatry.
So he takes it to the psychiatrist.
Exactly. He convinced two prominent psychiatrists, Jean Delay and Pierre Dennecker, to try giving this surgical drug to acutely psychotic, highly agitated patients on their wards.
And the orchestra actually quieted down.
It was revolutionary. Chlorpromazine became the prototypical first-generation antipsychotic. For the first time in human history, doctors watched patients who had been hallucinating and raving for months suddenly become quiet, lucid, and capable of holding a normal conversation.
That must have felt like magic.
It didn't just sedate them, you see. It actually dismantled the psychotic architecture. This single discovery initiated the psychopharmacological revolution and led directly to the massive deinstitutionalization movement, emptying out the asylums globally over the next few decades.
But there was a parallel discovery happening right around the same time. The text brings up a plant derivative, reserpine.
Yes, derived from the raw wolffia plant. In India, roots of this plant had been used for centuries for various ailments. By the 1950s, Western medicine had isolated the active alkaloid reserpine and was using it for hypertension.
Blood pressure.
Right. But clinicians noticed it also had potent antipsychotic properties, very similar to chlorpromazine.
But if it worked just as well, why don't I see reserpine on modern psychiatric formularies?
Because of how it worked, which actually teaches us a vital lesson about the brain. Reserpine is an irreversible vesicular monoamine transporter inhibitor, a VMAT inhibitor.
Okay, hold on. You need to break that down. What does a VMAT inhibitor actually do?
Right, so inside a neuron, neurotransmitters like dopamine, serotonin, and norepinephrine are stored in little protective bubbles called vesicles before they are released into the synapse. The VMAT is the pump that loads the transmitters into those bubbles.
Okay, the pump fills the bubbles.
Reserpine permanently destroys that pump.
So the neurotransmitters can't get into the protective bubbles.
Exactly. And because they are left unprotected in the cell, they get chewed up and destroyed by enzymes. Reserpine literally depletes the entire brain of dopamine, serotonin, and norepinephrine. Now, because it depleted dopamine, it cured the psychosis. But because it simultaneously depleted all the serotonin and norepinephrine, it caused profound, debilitating, and sometimes suicidal depression in these patients.
Okay, so you stop the voices, but you plunge the patient into absolute despair. I can see why they abandoned it. But this leads perfectly into how we understand the brain today, doesn't it? Because if depleting dopamine stopped the psychosis, that told researchers that dopamine was the key.
Precisely. The medical community shifted entirely away from reserpine and towards chlorpromazine and its successors. Because chlorpromazine didn't deplete the brain's dopamine, it just blocked the dopamine receptors on the receiving end.
Let's dig into that mechanism. Because if I look at the drug market today, there are dozens of antipsychotics, different brand names, different chemical structures, massive marketing campaigns claiming this new pill is revolutionary. But underneath all of that, what is the grand unifying theory here?
The grand unifying theory of antipsychotic efficacy is remarkably simple. Despite all the marketing, every single medication currently approved and available to treat psychosis shares one core, non-negotiable mechanism. They all reduce postsynaptic dopamine receptor activity, specifically at the dopamine D2 receptor.
But wait, if they all do the exact same thing, why do we have this massive divide between first-generation antipsychotics, the FGAs, and second-generation antipsychotics, the SGAs? What actually makes an SGA different if they're both just blocking D2 receptors?
The difference lies in specificity and additional receptor targets. First-generation antipsychotics like chlorpromazine or haloperidol are essentially strict, rigid D2 receptor antagonists. They are blunt instruments that lock onto the D2 receptor and absolutely refuse to let go.
Okay.
Second-generation antipsychotics, starting with clozapine in the 1970s and 80s and moving to drugs like risperidone and olanzapine, combine that D2 antagonism with potent blockade of serotonin receptors, specifically the serotonin 2A receptor.
Let me test an analogy on you to see if I'm grasping the receptor mechanics, because this can get incredibly abstract.
Go for it.
Let's imagine the postsynaptic D2 receptors in the brain as chairs in a high-stakes game of musical chairs. The dopamine molecules are the people frantically trying to sit down.
Okay.
In the psychotic brain, the music is blaring, there are far too many people, and they are aggressively fighting for every single chair.
It's an excellent visual.
So an FGA, a strict antagonist like haloperidol, comes in like an aggressive bouncer. It grabs 60 to 70% of those chairs and literally bolts them to the ceiling. No one can sit there. The dopamine is entirely blocked from those specific receptors.
And that 60 to 70% number is not arbitrary at all. Extensive neurobiological research, heavily supported by positron emission tomography (PET) scans of living human brains, has proven that to achieve antipsychotic efficacy, to actually make the hallucinations stop, an FGA must occupy approximately 60% to 70% of the D2 receptors in the striatum.
So that's the therapeutic window. What happens if you only bolt down 50% of the chairs?
The patient remains psychotic. The music keeps playing.
And what if I bolt down 85% of the chairs? If 70% is good, 85% must be better, right?
That is a very dangerous assumption, and it's where the analogy of the bouncer really matters. If you occupy more than about 78% or 80% of those D2 receptors, you do not get any additional antipsychotic benefit.
Really?
None. None. The voices don't get any quieter, but you drastically, almost exponentially, increase the risk of severe motor side effects, which we will get into later. You cross the threshold of toxicity.
Okay, so that's the rigid FGA bouncer. But what about the newer class of SGAs? Drugs like aripiprazole or brexpiprazole. I read they are partial agonists. If they are partial agonists, they aren't bolting the chair to the ceiling.
No, they aren't. In your analogy, a partial agonist is someone who sits in the chair, but they only take up half the seat and they don't jump up and down.
Right.
They occupy the space, preventing the aggressive dopamine from sitting there, but they still provide a tiny bit of gentle stimulation to the chair themselves.
But if they are still providing stimulation, How do they stop the psychosis?
Because the intrinsic stimulation they provide is far, far lower than what the brain's natural dopamine would do. They act as a dimmer switch, not an off switch.
Okay.
But because they don't fully block the signal, they have to occupy vastly more receptors to achieve the same overall reduction in brain signaling. The PET scan data shows that partial dopamine D2 agonists need more than 90% receptor occupancy to be effective.
Over 90%. They have to sit in almost every single chair just to keep the room at a low hum. That is fascinating. But then there's clozapine. Every time I read about psychopharmacology, clozapine breaks the rules.
Clozapine is the ultimate outlier. Clozapine, along with quetiapine and a much newer drug called lumateperone, are highly unusual because they appear to achieve clinical efficacy with only about 40% postsynaptic D2 occupancy in the striatum.
How does that even make sense? If the golden rule is 60 to 70%, how is clozapine clearing a psychotic episode with only 40% of the chairs covered?
It remains an area of intense neurobiological debate. The prevailing theory relies on its fast-off kinetics.
Fast-off kinetics.
Yes. Clozapine binds to the D2 receptor, but it dissociates. It lets go very rapidly. It doesn't bolt the chair to the ceiling. It just taps it and moves on. This allows for normal physiological bursts of dopamine to still get through, which might explain why it causes fewer motor side effects.
Okay, that makes sense.
Furthermore, clozapine doesn't just target D2. It is a massive pharmacological shotgun. It binds to serotonin 2A, 2C, muscarinic acetylcholine receptors, histamine receptors, and alpha-adrenergic receptors. It tunes the entire orchestra simultaneously rather than just muting the brass section.
Which brings us to one of the most frustrating mysteries in psychiatry. The text outlines this time lag issue.
Yeah.
Let's say I'm an A&E. I have a patient in a severe psychotic state. I give them an intramuscular injection of an antipsychotic. That drug hits their bloodstream, enters the brain, and binds to those D2 receptors. How long does it take for those chairs to be occupied?
For an intramuscular injection, peak plasma levels are reached in about 30 minutes. Even for an oral tablet, it hits peak concentration in the blood within 1 to 6 hours. The physical blockade of those D2 receptors happens almost immediately.
Right. So the chairs are blocked on day 1. Why doesn't the psychosis stop on day 1? The patient might calm down because they are sedated, but they will tell you they're still hearing the voices for weeks. If the mechanism is just blocking dopamine and the dopamine is blocked instantly, why does it take up to 6 weeks for the delusions to dissolve?
Because blocking the receptor isn't actually the cure, it's just the catalyst. This tells us something profound about the pathogenesis of schizophrenia. The therapeutic response does not depend solely on the immediate mechanical blockade.
Okay.
If it did, it would work like a light switch. You flip it, the room goes dark. Instead, clinical improvement depends on complex downstream neurobiological processes that are triggered by that chronic blockade.
What exactly is happening downstream during those 4 weeks?
You are forcing the brain's genetic machinery to adapt. By chronically starving those postsynaptic neurons of dopamine, you trigger changes in gene expression. The neurons alter how they synthesize receptors, they change their firing rates, and they gradually rewire the aberrant circuitry. The text notes this is supported by measuring plasma homovanillic acid, or HVA.
What is homovanillic acid?
It's a primary metabolic byproduct of dopamine. When dopamine is broken down in the brain, it turns into HVA, which eventually enters the bloodstream.
Okay, so it's a marker.
Right. Studies show that when you first give an antipsychotic, HVA levels actually spike because the presynaptic neurons panic that the signal isn't getting through and pump out more dopamine.
Oh, wow.
But over the next few weeks, as the brain adapts and downregulates its firing, HVA levels steadily drop. The decline in HVA strongly correlates with the timeline of clinical improvement. You aren't just turning down the volume, you are forcing the amplifier to rebuild itself.
But that creates an immense real-world problem. If the brain takes a month to rebuild the amplifier, what on earth do we do with the patient who is terrified, agitated, and tearing up the emergency department on day 1?
It is the crucible of acute psychiatric care. When you have a patient in an acute psychotic crisis dominated by positive symptoms, hallucinations, delusions, disorganized behavior, you have to manage the immediate danger while setting the stage for long-term recovery.
I want to focus on the urgency here, because if it takes weeks to work anyway, what's the rush? If a patient is brought in, why does it matter if we wait a week or 2 to start the dopamine blockers?
It matters immensely for the long-term trajectory of their life. There is a vast body of literature synthesized in a major review by Howes and colleagues, focusing on the duration of untreated psychosis, or DUP. The data is unequivocal. Lengthy delays in initiating dopamine receptor blocking treatment are toxic to the patient's future.
Toxic in what way?
The Howe's review looked at multiple measurable outcomes. A longer duration of untreated psychosis was significantly associated with worse symptomatic outcomes down the line. They have a lower chance of full remission. They have worse social functioning, worse vocational outcomes, and poorer cognitive function.
Just from waiting a bit.
Yes. There is even compelling neuroimaging data suggesting that untreated active psychosis may be associated with progressive cortical volume reductions.
Wait, you're saying the psychosis itself is actively destroying brain tissue over time?
That is the prevailing hypothesis. An untreated hyperdopaminergic state seems to be neurotoxic. The longer the brain is allowed to operate in that chaotic, inflamed state, the harder it is to ever bring it back to a baseline of recovery. Time is quite literally brain.
But you can't just blindly rush in with a needle the second someone looks psychotic.
Yeah.
If I'm an A&E doctor, someone comes in talking to the walls, I can't just diagnose schizophrenia in 5 minutes.
Absolutely not. The text demands clinical restraint and rigorous medical reasoning. First episode psychosis is a diagnosis of exclusion. You must prove it isn't something else.
Right.
A brief delay is mandatory to conduct a comprehensive medical workup because countless organic physical illnesses masquerade as psychiatric emergencies.
Give me the checklist. What am I looking for before I commit this person to a life-altering antipsychotic?
The most common culprit is substance intoxication or withdrawal, methamphetamine, cocaine, phencyclidine, high-potency synthetic cannabinoids. You need a comprehensive toxicology screen.
Okay, toxic screen.
But beyond that, the textbook mandates a thorough physical and neurological exam. You need blood work, a complete blood count, electrolytes, renal, and liver function. You need to check their thyroid because thyrotoxicosis can cause acute mania and psychosis.
Why do I need fasting glucose and lipids right away? They're psychotic, they aren't having a heart attack.
Because the moment you start them on these medications, you are going to massively alter their metabolism. You must establish a baseline. Patients with schizophrenia already have elevated risks for diabetes and cardiovascular disease.
Fair point.
You also need an electrocardiogram to check for prolonged QTC intervals or underlying cardiac issues. And perhaps, most critically today, in any case of sudden onset atypical psychosis, especially if accompanied by autonomic instability or subtle neurological signs, you must consider a brain MRI and a lumbar puncture to test for autoimmune encephalitis.
Like anti-NMDA receptor encephalitis.
Exactly. It frequently presents with severe psychiatric symptoms, paranoia, hallucinations, severe agitation before the neurological seizures start. If you misdiagnose an autoimmune brain inflammation as schizophrenia and just heavily sedate them with antipsychotics, the patient could die from a highly treatable disease.
Okay, let's say we've done the workup. The tox screen is clean, the MRI is clear, the thyroid is fine. It is a genuine first episode of schizophrenia. This patient is experiencing this for the very first time. Do I treat them the same way I treat the 50-year-old patient who has had the disease for 2 decades?
No, and failing to understand this difference is a major clinical error. First episode patients possess a unique neurobiology. Their brains have not been exposed to years of chronic illness, and more importantly, their dopamine receptors are completely naive to pharmacological blockade.
So they respond better.
They are highly treatment responsive. The vast majority will see a significant remission of positive symptoms. However, because their system is completely naive, they are exquisitely, dangerously sensitive to side effects. The text specifically highlights that first episode patients require much lower doses, typically about 50% of the dose you would give a chronic patient.
So if a standard dose of risperidone for a chronic patient is 4 to 6 milligrams, what am I giving the 19-year-old first episode patient?
You might start at 1 or 2 milligrams. If you blast a first episode patient with a heavy, chronic dose, they will experience intolerable side effects, severe sedation, terrifying restlessness, stiffness. And think about the psychology of that moment. You have a terrified teenager already struggling to accept that they have a chronic mental illness, and your pill makes them feel like a zombie trapped in a rigid body. What are they going to do?
They're going to throw the pills in the bin the second they leave the hospital.
Exactly. You induce non-adherence, which leads to immediate relapse. The first experience with medication must be handled with profound delicacy.
But let's go back to the locked ward. I have that agitated patient. I can't wait weeks for the pills to work, and I need to calm them down right now because they are a danger to themselves or the nursing staff. How do we safely manage acute agitation?
When de-escalation fails, you need rapid pharmacological calming. An intramuscular injection of an antipsychotic is standard. We used to rely entirely on IM haloperidol, but haloperidol, being a high-potency FGA, has a very high risk of triggering acute, painful muscle spasms called dystonias right there on the ward.
So what's the modern approach?
Today, the text suggests using IM formulations of second-generation agents like ziprasidone, olanzapine, or aripiprazole, which carry a much lower risk of acute motor side effects.
Why not just use a massive dose of a benzodiazepine? Just put them to sleep.
Benzodiazepines like lorazepam are actually excellent tools here. They provide rapid, reliable sedation, whether given orally or intramuscularly. In fact, co-administering a modest dose of an antipsychotic with lorazepam is generally much safer and more effective than just escalating the dose of the antipsychotic alone to dangerous levels.
But wait, I recall reading a massive, bolded warning in the textbook about combining these drugs.
You are thinking of the olanzapine warning, and it is a matter of life and death. Short-acting intramuscular olanzapine is highly sedating on its own. If you administer IM olanzapine, you must never combine it with a parenteral benzodiazepine like IM lorazepam within a 2-hour window, either before or after.
Why? What happens?
The combination can cause synergistic, profound respiratory depression and bradycardia. The patient can literally stop breathing. There have been fatalities. You have to pick one or the other or wait the mandatory 2 hours.
Good to know. Are there any other options for agitation that don't involve heavy sedation?
There is a very interesting newer agent mentioned in the text, dexmedetomidine. It's an alpha-2 adrenergic agonist. Anesthesiologists have used it intravenously in the ICU for decades to keep patients calm but easily arousable.
And we use it in psychiatry now.
Recently, sublingual and oral formulations have been approved specifically for acute agitation in schizophrenia and bipolar disorder. It suppresses the central sympathetic nervous system. It turns off the fight-or-flight adrenaline response, calming the patient significantly without the dangerous respiratory depression of high-dose benzodiazepines.
Okay, the crisis is managed, the patient is on the ward, and we start them on a daily oral dose. Now, he hits the dosing trap. I see this all the time. A week goes by. The patient is still delusional. 2 weeks go by. They still think the FBI is listening to their thoughts. The natural instinct of a young doctor is to think, the dose is too low, let's push it higher.
Right.
But hold on. If 70% receptor occupancy isn't stopping the voices, logic says I should push the dose until I hit 85% or 90%. Why doesn't that work?
It is the most common and damaging clinical trap in psychiatry. Let's debunk the myth of high doses using the textbook's explicit evidence. First, the timeline. While the full effect takes weeks, the text notes that the greatest relative reduction in symptoms actually occurs in the first 1 to 2 weeks.
Wait, really? The biggest drop happens early?
Yes. If a patient shows absolutely zero or minimal improvement in the first 2 weeks, assuming they're actually swallowing the pill, and you have reached a minimum therapeutic dose, that early non-response is a highly accurate predictor that they will never respond to that specific drug, even if you wait 3 months.
So you don't wait 6 weeks in vain.
Right. You either switch the medication or you increase the dose only if they are still on the lower end of the approved range. But to answer your question about pushing past the maximum limit going off-label to hit 85% occupancy, the evidence is definitive. Numerous dosage comparison studies and massive meta-analyses have entirely failed to support the routine use of doses higher than the upper approved limit.
It just doesn't work.
It does not increase effectiveness for acute treatment, and it does not prevent relapse any better. All it does is guarantee severe toxicity. Once you cross that 78-80% threshold of D2 blockade, the dopamine blockade in the other areas of the brain becomes absolute, and you paralyze the patient's motor system.
On the flip side, you can't be too timid either, right?
Correct. Doses below the lower level of the approved range significantly increase the risk of non-response and relapse. You must find the therapeutic window. For chlorpromazine equivalents, that's roughly 300 to 600 milligrams daily. For risperidone, 4 to 8 milligrams. For olanzapine, 10 to 20 milligrams.
Finding that exact right dose is paramount.
Yeah.
Because we need to talk about what happens when you get it wrong, or even when you get it right, but the body reacts poorly.
Yeah.
Let's dig deeply into the side effects, because if a treatment causes severe visible harm, the patient loses trust, they stop taking the drug, and the entire house of cards collapses.
Absolutely.
Let's start with EPS extrapyramidal side effects. To understand this, we need to go back to the neurobiology. We know dopamine in the mesolimbic pathway causes the hallucinations. But dopamine does other things in the brain, right?
Exactly. Dopamine is a multi-purpose neurotransmitter. While hyperactivity in the mesolimbic pathway drives the psychosis, dopamine in the gross striatal pathway is responsible for fluid, coordinated voluntary muscle movement. The extrapyramidal system, heavily involving the basal ganglia, relies on a delicate balance of dopamine and acetylcholine to let you walk, write, and control your posture.
But the antipsychotic pill doesn't know which pathway it's in.
That is the tragic flaw of these medications. When you flood the brain with a D2 antagonist to silence the mesolimbic pathway, you are unavoidably blocking the dopamine receptors in the nigrostriatal pathway as well. You starve the motor system of its fuel.
So by stopping the voices, we are quite literally causing movement disorders.
Yes. High-potency first-generation antipsychotics like haloperidol are the most notorious for this, but it is a massive, dangerous misconception that second-generation drugs don't cause EPS. They absolutely do, particularly at higher doses.
Let's walk through the three main types of acute EPS, so a clinician knows exactly what they are looking at on the ward. Let's start with the one that is hardest to diagnose. Akathisia. Imagine I'm in A&E, observing a patient. What does akathisia look like?
You might see a patient who just cannot stop moving. They are pacing the hallway continuously. If you make them sit down, they are rocking back and forth, constantly crossing and uncrossing their legs, shifting their weight from foot to foot.
That sounds exactly like a patient who is just extremely anxious or whose psychosis is making them agitated. How do I know it's a side effect and not just the schizophrenia?
That is the central diagnostic trap. If you ask the patient, they often struggle to articulate it. They will describe an intense, terrifying, subjective feeling of inner restlessness. They will say they feel like they're crawling out of their own skin or that their muscles are vibrating. It is a torturous sensation.
What happens if I misdiagnose it? If I look at this pacing patient, assume their schizophrenia is flaring up, and I increase their dose of haloperidol,
You will plunge them into an absolute nightmare. Increasing the dopamine blockade will dramatically worsen the akathisia. The text notes that severe unrecognized akathisia is highly correlated with impulsive, aggressive acts and even suicide, simply because the patient is desperate to escape the internal torment.
so how do you prove it's akathisia and treat it?
You can conduct a diagnostic trial. You administer a medication known to treat EPS. The standard of care for akathisia is a centrally acting beta blocker like propranolol.
Propranolol. I take that before public speaking to lower my heart rate. Why does a blood pressure medication fix a dopamine-induced movement disorder?
The exact mechanism is still slightly debated, but it's believed that blocking central beta-adrenergic receptors somehow modulates the downstream effects of the dopamine blockade in the motor pathways. If you give propranolol or sometimes a tiny dose of a benzodiazepine or an anticholinergic and the patient's desperate pacing melts away in an hour, you have your diagnosis.
Are there any tricks to avoiding akathisia with the newer drugs?
Yes, there is a fascinating clinical pearl regarding lurasidone. Lurasidone is an SGA that can cause significant akathisia. However, researchers found that if you shift the dosing schedule so the patient takes it right before bed rather than in the morning, the rates of akathisia plummet, even at higher doses.
Why? Does the brain process it differently at night?
It's likely about pharmacokinetics. The side effect seems tied to the peak concentration of the drug in the blood. If they take it at night, they sleep through that peak concentration window, and by the time they wake up, the levels have smoothed out enough to avoid the subjective distress.
Oh, that's clever.
Also, you need to be aware of the partial agonists, aripiprazole, cariprazine. Because they provide that gentle intrinsic stimulation, they can cause an early activating restlessness that looks exactly like akathisia.
Are you saying it's not real akathisia?
It's often just an initial stimulatory effect that subsides on its own over a few weeks. You manage it by titrating the dose up very slowly, perhaps covering them temporarily with an antihistamine, and you don't necessarily have to abandon the drug.
Okay, so that's the inner restlessness. What is the second type of acute EPS?
Acute dystonias. If akathisia is hard to diagnose, dystonia is impossible to miss. It is visually horrifying. Dystonias are sudden, sustained, severe muscular spasms and abnormal postures.
Paint the picture. What does it look like?
A young male patient, maybe 22 years old, is given an IM shot of haloperidol. A few hours later, his neck muscles suddenly violently contract, twisting his head to the side in a painful torticollis. Or his jaw locks open. His tongue feels swollen and protrudes, causing severe dysphagia. He can't swallow his own saliva.
That is terrifying.
The most dramatic is the oculogeric crisis. The extraocular muscles spasm, and the patient's eyes are forcefully, painfully deviated upward, locked staring at the ceiling, completely unable to look down.
What do? You can't just tell them to relax.
It is a psychiatric emergency. The most dangerous form, though rare, is laryngospasm, where the vocal cords spasm shut and cut off the airway. You do not give them an oral pill and wait. You immediately administer an intramuscular or intravenous anticholinergic like benztropine or an antihistamine like diphenhydramine.
Because acetylcholine and dopamine sit on a seesaw in the basal ganglia. If you pharmacologically crush the dopamine side with the antipsychotic, the acetylcholine side shoots up and causes the spasm.
Exactly. By giving an anticholinergic, you crush the acetylcholine side of the seesaw, restoring the balance, and the spasm literally breaks and melts away before your eyes within minutes.
That brings us to the third acute extrapyramidal symptom, which sounds like it mimics another disease entirely.
Drug-induced Parkinsonism. Because we are starving the nigrostriatal pathway of dopamine, we are artificially inducing the exact same pathophysiology seen in idiopathic Parkinson's disease.
So they get the classic tremor.
Arresting tremor, yes, but also severe muscular rigidity and most insidiously bradykinesia or akinesia, which is a profound slowing down or absence of spontaneous movement.
Let's play this out on the ward. A patient has been on risperidone for a month. How does akinesia present to the clinician's eye?
It's remarkably subtle at first. You might notice that when they walk down the hall, their arms don't swing. They just hang stiffly by their sides. Or you look at their face and it's completely blank. They have masked faces. They don't smile. They don't frown. Their voice loses its prosody and becomes a monotone whisper.
But wait, a flat face, lack of movement, lack of spontaneous speech, doesn't that look exactly like the negative symptoms of schizophrenia?
It is virtually indistinguishable, and this is another massive trap. If an inexperienced clinician looks at a patient with a blank face and assumes the schizophrenia is getting worse, that the negative symptoms are progressing, they might disastrously decide to increase the dose of the antipsychotic.
Which will just lock the patient further into the Parkinsonian state.
You are trapping them in a chemical straitjacket. If you suspect Parkinsonism, you need to lower the antipsychotic dose, switch to a drug with a lower EPS profile like quetiapine or clozapine, or add an oral anticholinergic medication to balance the seesaw.
But those anticholinergics aren't free candy either.
Not at all. They cause severe dry mouth, constipation, blurry vision, urinary retention, and in older adults, profound cognitive dulling and confusion. It is a constant pharmacological tightrope walk.
And all of these akathisia, dystonia, Parkinsonism are acute. They happen hours, days, or weeks after starting the drug. But there is a shadow that hangs over long-term antipsychotic use, a side effect that can become permanent, tardive dyskinesia.
Yes, tardive meaning delayed, and dyskinesia meaning abnormal movement. According to the DSM-5 criteria, these involuntary movements must emerge after at least 3 months of cumulative exposure to a dopamine receptor blocking agent.
What does TD actually look like? If I'm sitting across from a patient who's been on chlorpromazine for 5 years, what am I looking for?
In about 75% of cases, it manifests in the oral facial maxillary region. You will see uncontrollable lip smacking, sucking or puckering motions, constant chewing, or the tongue darting in and out of the mouth.
Just constant involuntary movement.
Yes. In more severe cases, it spreads to the limbs and trunk, causing choreothothotoid movements, irregular, dance-like writhing movements of the fingers, toes, and neck.
And you said this can be permanent, even if you stop the drug.
That is the tragedy of TD. In many cases, it is irreversible. The prevalence is staggering. Approximately 25% to 30% of patients treated long-term with first-generation antipsychotics will develop it.
30%, that's huge.
The risk is significantly lower with second-generation agents ranging from 7% to 20%, but it is not zero. And for older adult patients, the risk skyrockets.
We've known about this for decades. Have we just had to accept it as the cost of doing business?
Historically, yes. The only options were to desperately try lowering the dose or switching to clozapine, which has a near-zero risk of causing TD. But recently, the FDA approved 2 targeted medications specifically to treat tardive dyskinesia, deuterbinazine and valbenazine.
Wait, I recognize that suffix. Are these related to the VMAT inhibitors? Like reserpine from the 1950s?
Brilliant that you caught that. Yes, they are VMAT2 inhibitors. Remember, reserpine indiscriminately destroyed the VMAT pump, depleting everything and causing severe depression.
Right.
Deuterbinazine and valbenazine are highly selective. They gently and reversibly inhibit the VMAT2 pump, mildly depleting dopamine specifically in the motor pathways to calm the hyperactive, writhing movements of TD without causing the global depressive crash. It is a perfect example of taking a historical blunt instrument and refining it into a molecular scalpel.
That is a remarkable full circle moment for psychopharmacology. Okay, we've covered the motor system extensively, but we have to talk about the rest of the body, because the second generation antipsychotics were supposed to be our saviors from EPS, But they brought their own catastrophic baggage, the metabolic and endocrine fallout.
They absolutely did. Patients with schizophrenia already face a horrifying statistic. They have a life expectancy 15 to 20 years shorter than the general population.
20 years.
Yes. Some of this is genetic vulnerability, some is due to lifestyle factors like incredibly high rates of chain smoking, poor diet, and poverty. But the medications we prescribe are massive, undeniable contributors to cardiovascular and metabolic disease.
The textbook leans heavily on the Katie trial here. Walk us through that because it's cited constantly.
The Clinical Antipsychotic Trials of Intervention Effectiveness, or CATIE, was a massive, government-funded, pragmatic trial in the United States. They took real-world patients and randomized them to different antipsychotics to see what actually happens over 18 months. The metabolic data was deeply sobering.
Who were the worst offenders?
The trial, along with subsequent meta-analyses, definitively proved that clozapine and olanzapine and the FGA chlorpromazine carry the absolute highest risk for massive rapid weight gain, dangerously elevated fasting glucose, and severe lipid abnormalities.
So I give a patient olanzapine, it clears their hallucinations beautifully, but they might gain 40 pounds in a year and develop type 2 diabetes.
Exactly. You are trading a psychiatric crisis for a metabolic crisis.
Which drugs are on the safer end of the spectrum?
The agents with the lowest metabolic risk profile are aripiprazole, brexpiprazole, cariprazine, lumateperone, lurasidone, and ziprasidone. But even they are not entirely benign, especially when given to drug-naive, first-episode patients whose metabolisms are highly sensitive.
So monitoring is mandatory. What is the clinical protocol?
You must track objective data: baseline body weight, blood pressure, fasting glucose or hemoglobin A1C, and a full lipid panel. You repeat this at 3 months and at least annually thereafter.
And if they start gaining weight?
If the patient starts rapidly gaining weight, you don't just watch it happen. You intervene with dietary counseling. You consider switching to a metabolically friendlier drug. Or you proactively prescribe metformin or topiramate to combat the drug-induced weight gain.
And beyond the metabolic syndrome, there is the endocrine system, the hormones. We need to go back to our dopamine pathways for a second, right? Because we haven't talked about the tuberoinfundibular pathway yet.
Correct. The tuberoinfundibular dopamine pathway connects the hypothalamus to the pituitary gland. In a healthy brain, dopamine travels down this pathway and acts as the body's natural brake pedal on the release of a hormone called prolactin.
So dopamine stops prolactin from being released. What happens when I give a patient a heavy dose of a D2 antagonist?
You block the receptors in the pituitary. You completely remove the brake pedal. Without dopamine to suppress it, prolactin levels skyrocket, causing a condition called hyperprolactinemia.
What does hyperprolactinemia actually do to a human body?
It suppresses the gonadotropin-releasing hormone axis, leading to severe reproductive and sexual dysfunction. In women, it causes amenorrhea, the complete cessation of menstrual periods. It can cause galactorrhea, which is the inappropriate production and leaking of breast milk in both men and women. It causes severe decreased libido, erectile dysfunction, and anorgasmia.
That is utterly devastating to a patient's quality of life.
Yeah.
And does it have long-term physical risks?
Yes. Chronically elevated prolactin suppresses estrogen and testosterone, which are vital for bone maintenance. Over years, it leaches calcium from the bones, leading to decreased bone mineral density, osteopenia, and early-onset osteoporosis.
Which drugs are the worst for this?
All of the first-generation antipsychotics raise prolactin. Among second-generation drugs, risperidone and its active metabolite paliperidone are notorious for causing massive prolactin elevations.
Wait, so we're giving them a drug that causes a severe hormonal problem. Is there a fix, or do we just have to live with it?
There is an elegant pharmacological fix. Let's say you have a patient whose psychosis is perfectly controlled on risperidone, but their prolactin is sky high, and they are suffering. You don't want to stop the risperidone and risk a psychotic relapse. So you can add a tiny dose, 5 to 15 milligrams of aripiprazole.
Wait, so we're giving them a drug that causes a problem, and then giving them a tiny dose of another antipsychotic just to fix the side effect of the first one. That sounds like a pharmacological house of cards. Is that really safe?
It sounds precarious, but logically it is incredibly sound. Remember, aripiprazole is a partial dopamine agonist. It binds very tightly to the D2 receptor, tighter than risperidone does. When it reaches the pituitary gland, it outcompetes the risperidone for the receptors.
Oh, I see.
Once it binds, because it is a partial agonist, it provides just a tiny whisper of intrinsic dopamine stimulation, just enough to reapply the brake pedal and normalize the prolactin levels without disrupting the antipsychotic effect in the mesolimbic pathway.
That is deeply impressive neuropharmacology. But let's face the grim reality. We are carefully balancing the mesolimbic pathway, the motor system, the metabolism, and the hormones. We tweak the doses, we manage the side effects, the patient takes the pills religiously, and they are still hallucinating.
Yeah.
What happens when the balancing act fails?
We enter the realm of treatment resistance. The textbook is very clear about the statistics. While 40% to 50% of acute psychoses will achieve a relatively complete remission of positive symptoms, the remaining 50% to 60% of patients will improve, but will still be left with persistent, chronic, positive symptoms. The voices never fully stop.
So if the first key doesn't unlock the door, do we just keep slamming our shoulder into it, or do we check if we have the wrong door?
You must always check the door. Before you brand a patient with the heavy label of treatment-resistant schizophrenia and start prescribing exotic polypharmacy, you have to verify the absolute basics. First, is the diagnosis even correct? Are you missing a subtle temporal lobe epilepsy? Second, is there ongoing hidden substance abuse? If they are smoking methamphetamine every weekend, no amount of risperidone is going to clear their paranoia.
And the most obvious one? Are they actually swallowing the pill?
Non-adherence is the rule, not the exception in this illness. But you cannot just accuse the patient of lying. You must check plasma blood levels of the drug, especially for medications where therapeutic blood levels are well established, like haloperidol, risperidone, and clozapine.
What if the blood level comes back at 0, but the patient swears they take it every morning while you watch them?
Then you have to look at pharmacokinetics. Maybe they have a genetic polymorphism in their cytochrome P450 liver enzymes, like the 1A2 or 2B6 enzymes. They might be an ultra-rapid metabolizer. Their liver chews up and destroys the drug before it ever reaches the brain.
Are there any other reasons the drug wouldn't make it to the blood? Like, what if they take it but it just passes straight through them?
Absorption nuances are highly relevant, specifically regarding food. The text explicitly highlights ziprasidone and lurasidone. Ziprasidone requires a minimum of a 500 kilocalorie meal to be adequately absorbed from the gut into the bloodstream. Lurasidone requires at least a 350 kilocalorie meal.
So if a patient wakes up, takes their ziprasidone with a single sip of black coffee, and goes about their day,
They are absorbing a fraction of the intended dose. They are going to remain psychotic. They aren't treatment resistant. They are underdosed due to a pharmacokinetic failure.
okay, let's say we've done our due diligence. The diagnosis is rock solid.
Yeah.
They were eating a massive breakfast with their ziprasidone. The plasma levels are perfectly in the therapeutic range. They failed 2 adequate trials of entirely different antipsychotics. They are still profoundly tormented by voices. What is the ultimate fallback?
The clozapine imperative.
Clozapine. We mentioned it earlier as the drug that breaks the receptor rules. Explain the history here, because this drug has an almost mythological status in psychiatry.
It does. It was actually discovered in the late 1950s, but its true power wasn't understood until a pivotal 1988 multi-center trial led by John Kane, the author of our chapter. He gathered a group of the most severely psychotic, highly refractory patients, people who had failed at least 3 different drug trials and were considered hopeless. He ran a double-blind comparison of clozapine versus chlorpromazine.
What did he find?
The results were staggering and changed the field. At the end of 6 weeks, only 4% of the patients on chlorpromazine met the strict criteria for clinical improvement. But 30% of the clozapine patients met the criteria, and if you kept them on clozapine for 6 months, up to 60% of these previously hopeless patients saw significant improvement.
That's a massive difference.
Every major trial since, including the American Katie trial and the British Cutlass study, has confirmed that clozapine is the undisputed heavyweight champion for refractory schizophrenia.
But hold on. If it's the undisputed champion, if it works when nothing else does, and it has almost 0 risk of causing tardive dyskinesia, why is it relegated to third-line treatment? Why isn't every patient given clozapine on day 1?
Because clozapine is a pharmacological beast that requires immense respect. It carries a heavy monitoring burden due to life-threatening risks. The most infamous is a granulocytosis.
Break that down. What is a granulocytosis?
It is a sudden, idiosyncratic, catastrophic drop in the patient's absolute neutrophil count, their white blood cells. The bone marrow essentially stops producing the cells that fight off bacteria. It leaves the patient completely lethally defenseless against everyday infections. It occurs in about 0.3% to 1% of patients, usually in the first few months.
That is terrifying. How do you prevent them from dying of a common cold?
Mandatory, strict hematological monitoring. In the United States, for example, a patient cannot legally be dispensed a clozapine pill unless their blood work is logged in a national registry. They must have a blood draw every single week for the first 6 months, then every 2 weeks for the next 6 months, and once a month for the rest of their life while on the drug.
That is a massive logistical nightmare for a patient whose life is already chaotic due to schizophrenia.
It is a huge barrier to entry, but agranulocytosis isn't the only risk. At doses above 600 milligrams, clozapine carries a 5% risk of inducing grand mal seizures. It carries a risk of fatal myocarditis inflammation of the heart muscle. It causes profound sedation, massive weight gain, tachycardia, and severe hypersalivation. Patients frequently complain of waking up with their pillows soaked in drool.
So you only deploy the champion when you absolutely desperately have to.
Precisely. Though it's worth noting one unique, FDA-approved indication. Clozapine is the only antipsychotic specifically approved for reducing the risk of recurrent suicidal behavior in schizophrenia or schizoaffective disorder. For a patient plagued by unremitting suicidality, the risks of clozapine are often vastly outweighed by its ability to save their life.
Wow. Okay, we have focused extensively on the positive symptoms, the hallucinations, delusions, paranoia. But we need to pivot to the silent destroyers of functionality, the negative and cognitive symptoms. Because treating the psychosis doesn't mean you've cured the patient, right?
Far from it. The negative symptoms, the severe apathy, the lack of motivation, which we call avolition, the flattened affect, the poverty of speech, the profound social withdrawal, these are the symptoms that actually prevent a patient from holding a job, attending school, or maintaining a loving relationship. And the cognitive deficits, poor working memory, inability to focus, make navigating the world nearly impossible.
Do the dopamine blockers fix these?
Generally, no. In fact, D2 antagonists often make them worse. This is where clinical reasoning becomes paramount. We must rely on the conceptual framework developed by William Carpenter, who divided negative symptoms into two categories, secondary and primary.
What defines a secondary negative symptom?
A secondary negative symptom is caused by something else. It is a side effect of another process. For example, if a patient is socially isolated and refuses to leave their room, is it because they lack the biological drive to socialize, which would be primary, or is it because they have a terrifying paranoid delusion that the neighbors are assassins?
That would be secondary.
Right. If they aren't speaking and have a blank face, is it the disease, or is it EPS-induced akinesia? If they lack energy, is it schizophrenia, or are they profoundly depressed or overly sedated by their medication?
You treat secondary negative symptoms by fixing the underlying cause. You clear the delusion, you lower the dose of the sedating drug, you treat the Parkinsonism, you add an antidepressant.
Correct. But if you strip all of that away and the patient is still profoundly apathetic and cognitively blunted, you are dealing with primary negative symptoms. The disease process itself has eroded their volition.
And what pill do we have for that?
The textbook is starkly honest here. There is currently no strong, definitive evidence that any available antipsychotic is highly effective for primary negative or cognitive symptoms. There is one 6-month trial suggesting the partial agonist Chlorpromazine showed some superiority over risperidone for prominent negative symptoms, but is far from a cure.
So where does the future of psychiatry lie? If dopamine only fixes half the problem, where are the researchers looking?
The frontier of drug development has finally moved beyond the D2 receptor. The text highlights several novel targets in clinical trials: muscarinic autoreceptor agonists, trace amine-associated receptor, or TAR1 agonists, and glycine transport inhibitors aimed at the glutamate system.
That sounds promising.
It is. And importantly, regulators have mandated that for a drug to be approved for cognitive impairment, it cannot just improve a score on a memory test. It must demonstrate a functional co-primary outcome. It must definitively prove it improves the patient's actual ability to navigate daily life.
Let's move to the final clinical reality: maintenance, relapse, and the big picture. I want to address you, the listener, directly. Put yourself in the clinician's chair. Sitting across from you is a 24-year-old patient. They had a severe psychotic break 2 years ago, but they've been on a daily oral antipsychotic ever since. They are stable, they are back in university, they feel great, but they look at you and say, "I'm sick of feeling sluggish, I've gained 20 pounds, I'm cured, I want to stop my medication." What do you tell them?
You have to provide them with the stark statistical reality of the disease, balanced with immense empathy. We have pooled massive amounts of long-term data on this exact scenario. If a stable, remitted patient stays on their maintenance medication, their risk of experiencing a psychotic relapse within the next year is roughly 15% to 25%.
Okay, so there's still a risk, but it's relatively low. What if they stop the pill?
If they stop their medication, the relapse rate skyrockets to 50% to 75% within a year.
50 to 75%. It's a coin flip weighted heavily against them.
Stopping medication is the single most significant risk factor for relapse we know of. Even if a patient has only ever had one single psychotic episode in their entire life, statistics show they still face an 80% chance of relapsing within the next 5 years if they abandon treatment.
That is a brutal truth to deliver to a young person trying to reclaim their life.
It is the ultimate psychoeducational challenge, because a relapse isn't just a brief return of symptoms. A severe psychotic relapse can destroy the life they've rebuilt. It can lead to academic failure, loss of employment, social ruin, homelessness, or catastrophic suicidal behavior.
Yeah, the stakes are incredibly high.
Furthermore, as we discussed earlier, every psychotic break may cause further neurotoxic damage to the brain, making it harder to reach baseline again.
So how long does the textbook recommend they stay on it?
For multi-episode patients, the guidelines generally advise at least 5 years of stability. However, the text adds a very sobering caveat. The implication that stopping the drug after 5 years is suddenly safe is an illusion. Therefore, many experts recommend pharmacotherapy on an indefinite or for the foreseeable future basis.
Indefinite. Which brings me to a massive contradiction in the text. I need you to reconcile the mortality paradox for me.
Okay.
We spent 20 minutes talking about how these drugs cause metabolic syndrome, weight gain, lipid spikes, and diabetes. They are objectively hard on the cardiovascular system.
Yes, they are.
Yet the epidemiological data clearly states that patients with schizophrenia who stay strictly compliant with their antipsychotics actually have reduced all-cause mortality and reduced cardiovascular mortality compared to those who stop taking them.
Yeah.
How is it medically possible that a drug that causes metabolic disease prevents cardiovascular death?
It sounds impossible, but the answer is profoundly human and is revealed through large within-subject data analyses. When a patient with schizophrenia is stable and maintained on their antipsychotic, your brain is organized. They possess executive function.
Right.
Therefore, they are capable of navigating the healthcare system. They show up for their primary care appointments. They are compliant with their statins, their antihypertensives, and their diabetes medications. They have the mental wherewithal to engage in psychosocial care and perhaps smoke a little less.
The antipsychotic organizes their mind just enough so they can actually take care of their physical body.
Exactly. When they abandon the antipsychotic, they descend back into the chaos of psychosis. They stop taking all their other life-saving medications, their diet deteriorates completely, their chain smoking escalates, they become isolated, and the unmanaged cardiovascular disease ultimately kills them. The systemic survival benefit of psychiatric stability vastly outweighs the direct metabolic toxicity of the drug.
That is an incredible holistic insight, and it perfectly underscores why adherence is the holy grail of treatment. Which brings us to the final major tool in our arsenal to guarantee that adherence: long-acting injectables, or LAIs.
Non-adherence rates with daily oral pills are astronomical. Over 40% to 50% of patients become non-compliant within a year or two. LAIs bypass this entirely. There are depot formulations. You inject the medication deep into the gluteal or deltoid muscle, where it forms a crystalline reservoir that very slowly dissolves, releasing a steady stream of medication into the blood over weeks or even months.
We have LAIs for older drugs like haloperidol, decanoate, and now we have them for the SGAs. Risperidone, paliperidone, aripiprazole. Some are given every 2 weeks, some every month, and some formulations of paliperidone only require an injection every 3 or even 6 months.
It completely revolutionizes adherence, but the clinical philosophy surrounding LAIs desperately needs to shift. Historically, psychiatrists viewed the needle as a punishment. You only used an LAI on the bad, non-compliant patients who refused to take their pills, often forcing it upon them.
Right. If you don't take your pills, I'm going to give you the needle. A terrible dynamic.
Toxic. The text strongly advocates that LAIs should be viewed as a frontline preventative tool offered to everyone. Think about the psychological burden of a daily pill. Every single morning when that patient swallows their risperidone, they are forced to remember that they have a severe, chronic psychiatric illness.
An LAI provides freedom from that daily reminder.
It provides immense psychological freedom, and physiologically, they are superior. Because there is no daily pill being rapidly absorbed and metabolized, there are no massive daily peaks and troughs in the blood level.
Oh, that makes sense.
The steady release means you often see far fewer peak concentration side effects. Across massive naturalistic cohort studies and mirror image studies, LAIs consistently prove superior to oral drugs in preventing relapses and hospitalizations. When introduced collaboratively through shared decision-making, patients frequently prefer them.
Okay, we have covered an immense amount of ground today. from the terrifying insulin comas of the 1930s to the receptor occupancies, the motor side effects, the metabolic fallout, and the 6-month LAIs of today. It is time to transition into our assessment phase to lock in these mental models. I'm going to speak directly to you, the listener. Let's do some rapid-fire clinical role play to pressure test what we've covered. I'll give you a scenario, you take a brief pause to think of the answer, and then our expert will break down the clinical reasoning. Here we go. Scenario 1. Let's look at receptors. I have a PET scan in front of me. The patient is taking an antipsychotic, and the scan shows that 92% of their D2 receptors in the striatum are currently occupied. However, the patient is completely free of any extrapyramidal motor side effects. What specific class of medication must they be taking?
They must be taking a partial D2 agonist, such as aripiprazole, remember the musical chairs. An FGA or standard SGA blocking 92% of receptors would cause catastrophic, rigid Parkinsonism. But because a partial agonist still provides a tiny whisper of intrinsic dopamine stimulation, it requires over 90% occupancy just to achieve antipsychotic efficacy without necessarily paralyzing the motor system.
Scenario 2. I'm the A&E doctor. A 22-year-old male was brought in deeply agitated and given an intramuscular injection of haloperidol. 3 hours later, I get paged. The patient is in agony, his neck is violently twisted to the right, and his eyes are locked staring at the ceiling. What is happening, and what is my immediate order?
The patient is experiencing an acute dystonia, specifically an oculogeric crisis combined with torticollis. This is a terrifying medical emergency caused by the sudden drop in dopamine signaling in the basal ganglia, which allows acetylcholine to run rampant and cause severe muscle spasms. Your immediate order is an intramuscular or intravenous anticholinergic like benztropine or diphenhydramine to instantly block the acetylcholine and break the spasm.
Scenario 3. I am treating a patient with ziprasidone. I'm giving them 80 milligrams twice a day. They swear they're taking it perfectly, but they are still hearing voices, and when I check their plasma level, it is barely detectable. We rule out an ultra-rapid metabolizer genetic trait. What simple daily habit is ruining my treatment plan?
The patient is likely taking the ziprasidone on an empty stomach. Ziprasidone is highly dependent on food for absorption and requires a minimum 500 kilocalorie meal to enter the bloodstream effectively. Without the food, the bioavailability plummets, creating a state of pseudo-treatment resistance.
Scenario 4. I have a patient who has been on a high dose of risperidone for 2 months. The delusions have stopped, but their family is distraught. The patient just sits in a chair all day, their face is entirely blank, they speak in a monotone whisper, and when they walk, their arms don't swing. The family asks, is the schizophrenia destroying their personality? What is your differential diagnosis before you answer them?
Before assuming this is the natural progression of primary negative symptoms, you must rule out secondary negative symptoms caused by drug-induced Parkinsonism, specifically akinesia. The physical signs diminished arm swing and masked facies strongly point to the risperidone heavily blocking the nigrostriatal pathway. You must lower the dose or change the medication before concluding the disease itself has worsened.
Final scenario. I have a patient whose schizophrenia has devastated their life. I've sequentially tried them on maximum tolerated doses of olanzapine, risperidone, and haloperidol over the last 2 years. They are entirely adherent, but the paranoid delusions remain absolutely intractable. Based on the Kane study and the Katie trials, what is the single most evidence-based drug to prescribe next, and what is the major barrier to using it?
The next step is clozapine, the gold standard for treatment-resistant schizophrenia. The major barrier is the strict, mandatory hematological monitoring required due to the risk of a granulocytosis, the potentially fatal drop in white blood cells, which necessitates weekly blood draws for the first 6 months of treatment.
Excellent. We've locked in the concepts. As we wrap up this deep dive, I want to leave you with a final thought to ponder, building on the vast history we've explored today. We started this journey by looking back at the 1930s. We look at the sleep therapies, the prefrontal lobotomies, and the insulin comas, and we naturally shudder. We view them as barbaric, desperate attempts by well-meaning doctors to treat a profound brain disease with brutal, blunt trauma. Right now, in our modern era, we consider ourselves enlightened. We treat psychosis with targeted molecular agents. We have PET scans and receptor occupancy data. But in doing so, we globally blockade the brain's dopamine system. We routinely induce Parkinsonian tremors. We cause severe metabolic disease, massive weight gain, and diabetes. We alter hormones to the point of infertility, and we risk causing permanent, irreversible movement disorders like tardive dyskinesia.
It's sobering when you put it like that.
So here is the provocative thought. 50 years from now, When we finally crack the neurobiological code, when we are successfully targeting muscarinic autoreceptors or traceamines, beautifully tuning the orchestra without ever touching the dopamine system at all, will the future psychiatrists of 2076 look back at our era of D2 antagonists with that exact same historical shudder?
It's highly likely they will.
It's something to deeply consider the next time you write a prescription. Thank you for joining us on this deep dive into the source material. Remember to keep reading Chapter 12.1 alongside this discussion to solidify these clinical models. Until next time.